Good morning, and thank you for attending this student research education session today. My name is Jessica Hawley, and I am a current graduate student and nurse of 14 years. I've worked in public health and closely with the Tennessee Childhood Lead Prevention Program for 10 of those years. This connection actually prompted my interest about lead in young children in the Mid-Cumberland region in Tennessee, which is where I currently live and work. I want to draw your attention to this first slide with pencils. Pencils were thought for many years to contain a type of lead. In fact, growing up, they would always tell me that I needed a number 2 leaded pencil to complete one of my standardized tests. Pencils actually never were made of lead, but graphite, which is a form of carbon, not a type of lead component. You can't actually get lead poisoning from being stabbed with a graphite pencil. This slide emphasizes that we can be influenced by misinformation. The Take Part program that you're attending today is an effort to give healthcare workers, providers like you, awareness of risk and testing for lead in children. This information is to benefit clinicians, medical doctors, nurse practitioners, registered nurses, LPNs, particularly those who care for and see young families and children surrounding the Mid-Cumberland region. These are my educational and financial disclosures. I do want to state that I work for the Tennessee Department of Health currently, but they are not a sponsor of this research. This is specifically created during my graduate studies and in performing a research study. Any data collected from these sessions, including the pre and post education surveys, are voluntary and will be de-identified when the material is provided for coursework purposes. Also, any data collected will be de-identified and submitted for contact hours if you are a nurse being awarded that credit through the Georgia Nurses Association based on their requirements. If you're joining me virtually, you should have received both the pre-session survey and the consent form. I want you to take the time to review these and determine if you agree to participate today. If you've not received this consent form, please stop here and message myself. The information is provided in the next slide or next few slides. The target group for this research is the Mid-Cumberland region, and these are the counties that encompass that. Also, based on proximity, workers of the Davidson County, Nashville area are eligible for participation due to being in that surrounding area. Again, before the course, you're asked to complete a pre-session questionnaire along with completing that consent form. If you have not received it, please message me through email at the email provided on the slide. Do not continue your session until you do so. And don't worry if you don't know the answers. This is not a test. This is to assess your current knowledge before I provide education in this session. Here are the objectives of this education session. Participants should be able to understand the risks of lead poisoning, identifying those who are considered high risk, utilizing tools and resources to help facilitate testing and understanding of case management, gain awareness of updated blood reference levels and management of that level, following state requirements and Medicaid requirements of testing at 12 months and 24 months, all the way up to 72 months of age based on risks, and also provide education and improve understanding of families of young children for those who are at risk of lead exposure. First off, I want to talk about what lead is. It's actually a metal that's found naturally in the earth, and in small amounts has been used for durability. It's only when it's ingested or inhaled that it becomes a danger. I want to share a little bit here about how lead has been involved in our daily lives. Back in the time of the Romans, they invented the sewage and water aqueduct system, where they used lead pipes to move water through the city. This is the Pb in the periodic table and is derived from the word plumbium. Predictions have been made that the lead pipes actually used at that time could have been contaminating the water supply, leading to the downfall of the Roman Empire, relating it to the fact that lead can cause infertility in adults. Lead has been an issue that spans centuries and decades of public health changes. These are the most common sources of lead exposure in children, and I will go through these in the next few slides in more detail. Why is lead even a part of paint? It enhances colors and durability and actually helps colors last. Lead-painted homes were common through 1978, when health hazards were noted from lead dust and lead chips causing these issues. Lead is actually sweet to taste, and this is why children commonly lick and put chips into their mouths. We'll touch on a young child's behavior in future slides, but I wanted to share specifically on lead paint. The U.S. Consumer Product Safety Commission banned lead paint in 1977. This also involved toy and furniture manufacturing. And this is why that question about an aged home is asked on a questionnaire when doing a lead risk assessment. All this said, lead paint contamination is still the #1 exposure source for children. Many live in older homes that are more affordable. Also, manufacturers in other countries do not have such restrictions as the United States. We have outsourced our goods and manufacturing, leading to exposures from consumer products such as toys and other items. We get recalls regularly for lead-based paint items, and these include furniture, toys, and clothes. Contaminated soil is also a source of lead exposure, and this can be from major highways, which are related to leaded gasoline runoff. This also could be, again, from old paint dust that has accumulated and leached into the soil from exterior paint of homes. Soil can be tested before plotting a vegetable garden, and it's encouraged to do that. There's a resource in your packet that will be included. In the state of Tennessee, the UT Extension Office provides this ability to test soil before planting. Also, during an environmental investigation, soil is tested to determine that being a source. Solutions to prevent lead exposure from soil is to encourage families to remove shoes when coming in and out of doors, and regular cleaning of floors and washing hands regularly, especially when working in the dirt. Also, if a child is outside, to cover any soil or bare yard spots with a blanket or something like a sandbox prior to putting a child down, to help prevent exposure, whether or not you've tested for lead. Lead in water is also a common source, but I want to share that lead is not generally a concern in city or well water. It can be a problem once plumbing fixtures corrode, and generally some other areas would be if lead pipes were used in older homes that were built before 1986. The Tennessee Department of Health offers water testing to Head Start and early Head Start facilities that are licensed child care centers at no cost to ensure that water is safe for children to drink. And you can request a lead testing kit through the Tennessee Department of Health Laboratory Services staff, and a phone number will be included in your packet at the end of this session. Parents can also have water tested as part of an environmental investigation, especially if it's discovered that a child has an elevated lead level. Local hardware stores have test kits for water, but these aren't as reliable as the larger water collected samples in those environmental investigations. Also to note, water services generally test water at a selected number of lead service line locations, and customers residing in those homes are given those results and able to request those results regularly. Bathing in water that may be contaminated with lead should not affect a general person, as it doesn't absorb through the skin, but those who are bathing, if they ingest or drink the water from the bathing source, could be exposed to contaminated water in that instance. Here are some lesser known areas of possible lead exposure: imported pottery, scented candles, ammunition, cell phones, jewelry, cosmetics, mini blinds, imported toys, even spices. I want to share that not all spices from different continents, such as Asia, are a risk for lead, as the U.S. Food and Drug Administration and European safety authorities often monitor and regulate these imports to ensure safety. It's generally a risk with unregulated products or locally sourced products that don't undergo quality control measures. There is a recall resource where you can find any lead-based recalls of imported toys and clothes, particularly for those for children. All of these lesser known sources of lead exposure have been found and identified as sources of exposure right here in Tennessee. We're going to talk about the health issues and impacts. There are often no signs or symptoms of lead exposure, and many times continued exposure shows delayed effects when it's too late. There's no safe level of lead in the blood. So this is key in preventing exposure altogether. Many signs could look like other causes, so recognizing risks is important to differentiate the health issue being stemmed from lead. Many laws have been developed regarding lead and health risk. Lead in paint, a law for Residential Lead-Based Paint Hazard Reduction Act of 1992 was put into place with amendments all the way through 2005. Lead in water through the Safe Drinking Water Act of 1974, which has had several amendments. The EPA issued revisions to the lead and copper rule, which involves lead pipe replacement, continuing today. Lead in air, which involves generally industrial contaminants and pollution from emissions and gasoline. The Clean Air Act, which began in the 1970s and has had amendments throughout several phases all the way to 1996. Disposal of lead waste through the automobile battery recycling example and Resource Conservation and Recovery Act on how to dispose of lead products. There is no safe level of lead in the blood. Even low lead levels result in behavior problems such as irritability and impulsivity, learning difficulties, including lower IQ and hyperactivity, slowed or stunted growth, impaired motor skills, hearing problems, and anemia. At higher levels, children and people can have problems with kidney damage, high blood pressure and associated risks, seizure, coma, and on rare occasion, death. As you can see, even the low concentrations of 3.5, which is the level of where providers are asked to start providing case management, that there are learning and behavior difficulties associated. Who's at risk? Young children, those in lower poverty level, and immigrants are at higher risk than most. The American Academy of Pediatrics recommends that children ages 6 months to 6 years be screened for risk of exposure at well-child checkups. If the child is at risk for lead poisoning, a lead blood test should be drawn to check. Again, young children are at higher risk of lead exposure. During this time, their bodies and brains are growing more quickly than any other time in their growth cycle. Their bodies not only absorb lead more quickly, but their brains are more sensitive to the effects of lead. This age group has an added risk factor with the natural behavior of putting their hands in their mouths and chewing on things and pulling up on walls or windowsills during this stage of life. Lower poverty is another risk. Medicaid recipients are required to have blood lead levels tested at 12 months and 24 months, no matter if they have additional risks. If a child is less than 72 months of age and doesn't have a lead test documented, they should get tested. With lower poverty level, their risk factors are associated with lead exposure. This can be including the age of the home, as they may not be able to afford newer homes that wouldn't have lead-based paint or older pipes. Also, lower income families may not have the ability to provide full nutritious meals, and therefore absorption of lead or behavior of eating other items may be increased. Studies have shown that low-income families have higher lead concentrations in comparison to those of higher income households. Therefore, Medicaid requires that these children get tested at 12 and 24 months. Why do you think they need to be tested at both ages? Exposure may not be evident at initial testing. When a child is 0 to 12 months, for instance, they may not be as mobile. For example, my child wasn't crawling until he reached about 15 months of age, when he became able to walk more confidently and pull up on surfaces. At the crawling stage, he may not have been at risk based on where lead exposure opportunities were made. To note that completing a risk assessment questionnaire does not meet the Medicaid requirement. The Medicaid requirement is only met when the 2 lead tests are completed or the catch-up blood lead test is conducted. Immigrant children under 6 have up to 5 times greater risk of lead levels than children born in the United States. And those children may not qualify for Medicaid. Others at risk include those who are pregnant, as those who may be exposed to lead can transfer that to an unborn fetus, leading to developmental problems or miscarriage. Also, those children who are connected to somebody who works in a high-risk environment, such as a lead manufacturing plant, where the adult has lead exposure risk that can be transferred to a child. This is an important slide. Even if you have trouble reading this with the small font, it'll be included in your resources. It's important to use a comprehensive screening tool, not just limiting risk questions to a child's age or the age of a home, because there, as you have now learned, there are several other potential risks. We are going to utilize this comprehensive screening tool provided by the Tennessee Department of Health Lead Prevention Screening Program, which is available for you to use and will be included in your resource packet. Let's practice utilizing this tool through this case study with Kinsley. Kinsley is a 16-month-old who is into your office for a well child check. She lives in Montgomery County with her father, who's a full-time employee at a tech company, and her mom is a stay-at-home mom. Kinsley seems well developed with no sign of health issue. You notice that you don't have any previous documentation of lead exposure history. After having taken this Take-Part education course, you ask if she's had a lead test. Her mother is unsure. When you ask that general aged housing question, she answers her house was built in 1990. But you don't stop there. What is your next step to determine possible lead exposure? These are her mother's answers. The key thing to recognize here is that answering yes or I don't know should trigger your need to perform a blood test. Here she answered yes or I don't know to the following. Does your child live in or regularly visit a house built before 1978? This could include a daycare center, home of a babysitter, or a relative. She also answered, does your child eat or chew a non-food item like paint chips or dirt? When you ask her further about her answers, she states that Kinsley stays with her mother-in-law, who has a 1950s house and has eaten the dirt when her grandma takes her outside to play or as she sits while she gardens. Now you decide you would like to test. The next thing that you share is why and how you'll perform the blood test for Kinsley today. I want to share this link with you as well, also included in your resource packet. This is a new dashboard where you are able to see lead tests being performed in the state of Tennessee, where you may be able to identify potential risk and gather information and data. It is important to obtain a good capillary sample in your initial blood test. These are the steps for obtaining that sample, and in order to eliminate getting false elevations, etc. Note that a venous sample is needed to confirm any elevated capillary sample. And we no longer accept taking an additional capillary sample as a valid confirmation. For pediatric capillary samples, be sure to perform only this for an initial blood sample. This is to show where to obtain in best practice. This is a slide to show the reporting of lead levels into LeadTrack. If you utilize a LeadCare2 machine or POC testing device, you must report the lead level. Otherwise, most are reported through the laboratory that your clinic uses. All lead levels that are drawn by either method must be reported, not just the elevated ones. I've provided a link to this source so that you could see how and what information is obtained in LeadTrack. Slide is just to show for awareness so that you can be familiar what that reporting tool looks like. Once you get an initial lead test, it's recommended that you repeat the blood test obtained as a venous sample to confirm that the patient does in fact have an elevated lead level. This is the guidance on the timeline to confirm based on that initial result. I want to stress that the confirmatory sample should be done as soon as possible and no later than these recommended timeframes. This is different in comparison to the case management of an already confirmed sample, which is in Table 2. Once a venous lead level is confirmed, you'll need to provide case management, which includes repeated lead levels that are drawn based on this schedule. It's important to share with the family or parent of the child that the child needs to be scheduled for regular follow-up blood tests. If for any reason a parent's unable to visit their PCP clinic for any reason, the health departments across the state are able to help provide lead level testing to any child below the age of 72 months paid for through the Child Lead Prevention Program in Tennessee. When scheduling these patients for follow-up, this window of time frame is important to stay in compliance with the recommendations of the CDC in order to determine if the lead level is decreasing or increasing. Environmental investigations can be made for the following reasons. If their lead level comes back at greater than or equal to 15 micrograms per deciliter, they have persistently elevated lead levels which are 3 or more, or a provider requests it. I want to give you a hint. This may be a question on your post-education questionnaire after the session. If given a lead level that's less than 15 micrograms per deciliter, the attendee answering, if they're a MD or nurse practitioner, they can mark as appropriate that a environmental investigation be a correct answer. However, if you are a nurse or etc. attending the session, answering if the patient meets criteria for an environmental investigation to be marked, you would be incorrect. Pay attention to that piece. Case management and intervention is important for any child with an elevated lead. The Early Intervention Systems, TEIS referral is for any child with elevated lead levels up to the age of 36 months. They can provide resources to families as far as notable developmental delay and are able to provide services related to lead exposure, such as behavioral, speech, or occupational therapies. Child Special Services may be available as a supplement for chelation appointments or other healthcare related needs if there's an elevation in lead, or even to continue to help with appointments to other healthcare providers related to elevated lead concerns. Those with high lead levels over an extended period of time need intervention, particularly based on their developmental and behavioral symptoms most often. Those with high lead levels may take a long time to decrease when the source, even when the source has been removed. CSS, Child Special Services, is able to care for any child with a confirmed elevated lead level through the age of 16. Note that CSS generally serves children up to the age of 21. However, with elevated blood lead levels, surveillance data is captured for those above the age of 16 through an additional surveillance system related to exposures generally associated with work environments. Let's switch gears and do another case scenario for this 3-year-old named Oliver. Oliver arrived in Tennessee 4 months ago from India. His parents are in for a well child check and have not established care with a pediatrician yet. You've just received records from a community clinic that showed the child had a previous lead level drawn when they arrived with a capillary blood result of 19 micrograms per deciliter. What's your next step for this child? You explain that the child had a previous lead level that showed that it was elevated and continue to describe that that means that you need to do a repeat blood test to ensure that it's in fact elevated. You need to get the blood sample at this time from the child's vein to ensure accuracy, and continue to share with the parent that if the lead level is still high, that they will need to continue to monitor for change and come back for continued office visits. That in the next few days, you'll receive results and provide them with next steps. They can do several things to eliminate possible exposure in that time. You shared that it may be that there was an exposure back where they lived in India and it may have already been eliminated, but that you will take these steps just to ensure that that may be the case. Results have come back, and you call Oliver's parents to confirm that the child does in fact have an elevated lead level of 12 micrograms per deciliter. With this being lower than the previous result, your hope is that it continues to go down, but that based on the CDC guidelines, you need Oliver to come back again for another blood test. Based on this result, when would you need to see Oliver in your office for a repeat venous lead level? At this time in your session, feel free to look at your previous slide to determine the appropriate answer here. Based on CDC guidelines, Oliver is to come back for another repeated lead level in 1 to 3 months. Note that it's better to schedule at 1 month in case the parents need to reschedule or are no-shows. This will allow for a window of time that is in compliance with these recommendations. Next few slides, I want to discuss the importance of talking with families and enabling parents to protect their children through information that you provide. As healthcare workers and providers, we know that compliance increases with understanding. It's important to explain the reason for testing and important to discuss prevention techniques. Use the tools at your fingertips to help you in doing this and plan ahead. In a previous needs assessment, when I was interviewing a few families whose children had elevated lead levels, one parent didn't even know her child was tested for lead until case management was needed, when in fact, all 3 of her children had been tested according to guidance. The provider did well to meet the criteria based on Medicaid. However, he skipped a step and didn't explain the actual test to the parent. It wasn't until the need for case management and regular follow-ups that she even knew that her children had been tested for lead. The assumption was made that the child was being tested for iron. Some providers may worry about compliance and barriers based on the lack of desire for a blood test. It is through provider recommendation and education to a parent that decreases. Testing and follow-up, as well as expectations, are important to discuss to encourage compliance and follow-up. These are examples of how you can recommend testing as well to a parent. One of the key takeaways is to encourage a parent to voice any questions or concerns. I included this slide to show several actions that can be taken for a parent in order to limit or eliminate lead exposure altogether. Keeping homes clean and dust-free, eating diets high in iron, calcium, and vitamin C, washing hands, staying in the grass, hiring certified lead professionals, washing toys, pacifiers, and bottles, running your water, showering and changing clothes that might be contaminated, just to name a few. To address nutritional status, diet, and dietary behaviors. Those identified at risk for lead exposure may have poor nutrition or ability to afford nutritious foods. In those cases, be sure to refer to WIC, a resource at our health department. Empty stomachs can absorb more lead than children on full stomachs. Well-balanced diets and meals containing calcium, iron, and vitamin C help decrease absorption of lead in the body. A child's eating behaviors, eating with their hands, hand-to-mouth behaviors due to age, food preparation activities, storage in food-safe containers, preparing formula in a safe way, are all things that can be done and addressed to decrease lead exposure potential. Note that infants who drink formula prepared with lead-contaminated tap water may be at higher risk for exposure due to the large volume of water they consume relative to their body size. It's important not to use warm or hot tap water when preparing formula. And hot or boiling water actually can increase contaminants such as lead in water if it's present. So it's important to educate families to use cold tap water when they're mixing formula. Addressed lead transfer a bit related to occupations and hobbies in earlier slides. Each family can prevent transfer of lead through removing clothes and work shoes and leaving anything that could be contaminated away from a child access area. It's important to encourage showering completely, including washing hair of dust particles that can transfer, and not to bring any items that may have been affected into the home without wiping and decontaminating those items. Think about all the areas that your child plays or comes into contact with. This includes the car, outdoor play areas, particularly in areas of bare soil, and laundry room spaces where contaminated work clothes may be. Regularly and often. Fine dust particles are the biggest threat to children when inhaled or ingested, so anything you can do to get rid of potential dust is better. Refer to additional cleaning recommendations and practices in your resource packet. Warm soapy water is one of the best methods to cleaning lead dust particles. At the end of this course, you should have all the tools necessary to provide and manage effective care to families of young children before and after lead exposure. If you feel there's an additional resource that is needed, or you know of any additional information, please reach out through my email, fitchja@etsu.edu. Any additional tools not included at the end of the session that are added based on feedback and suggestion will be emailed to all participants as required. Now it's time to take part and take action. Screen and test often and early to prevent lasting problems. See what you've learned. Please inform me by email provided to you that you've completed your self-led virtual session in order to receive the post-session survey. This will be sent to you by the email you previously provided. If you are a nurse, you are able to receive nursing contact hours after completion of that survey. If you are not a nurse, however, this is not a requirement, and all participants will receive a certificate of completion for their record. References and resources are going to be sent to you via email and are encouraged to be used throughout your clinical practice. Lastly, you can submit any questions or concerns you may have to the email address provided, and please remember that you will receive 4 additional questions approximately 1 month after your initial session. Thank you for your time and taking part in learning today. Be sure to include your contact information at the bottom of your post-educational survey so that these can be linked to your follow-up material and resources appropriately. Thank you.